Thank you, sir. Thank you. And thank you, Dr. Vamshi, for making us understand the complexities of the HRD test. I'll be not taking much of the time and skipping the slides which have already been discussed. So this ovarian cancer, we all know, is the 5-year survival is dismal in advanced ovarian cancer. And once the disease relapses, it is incurable, and that's why the survival is poor. Now, the paradigm shifts in 2018 is that we have the availability of olaparib through Solo 1 in the first line, and we have Palova trial, which so this slide has already been discussed. I'll just go through it. That whatever insult, whether external radiation, chemo, or reactive oxygen species, or whatever insult happens, it causes a single stranded damage. Then it leads to double stranded damage, and the end result is that there is, whenever the repair is happening, there is a minor DNA repair, then the major DNA repair, temporary cell arrest, permanent cell arrest, and then transcriptional regulation, which ultimately leads to apoptosis and prevention of carcinogenesis. So when this pathophysiology, that this sensitive balance is damaged, we get the cancer cells. Now, as told previously, we were testing only just BRCA mutations maybe about 7 years back, in which we were able to diagnose germline somatic and germline mutation or somatic mutation of BRCA1 and BRCA2. Then it was thought that some more patients can be benefited with the PARP inhibitors. So HRR mutations were tested, which included CDK12, FA gene, core RAD genes, so such mutations. And altered HRR expressions were also noted. However, the difficulty is that when we are trying to identify the patients who will benefit from this therapy. So when we are looking for the cause of HRD, we are looking for the BRCA and HRR genes. But the effect of HRD, when we are trying to find out, that is loss of heterozygosity, telomeric allele imbalance, and large-scale state transition. So when we are able to identify these three also, then the spectrum of patients whom we can identify will benefit from PARP inhibitors increases significantly. So to make it more simple, that only 15% of the patient. If we do the 2% of the patient will be able to on the tumor, then about 50% of the patients we are able to identify. So by doing HRD, at least 50% of the patients will be able to identify who will benefit from the PARP inhibitors. So this is the significance of doing HRD and not.
I think he has lost connection.
I think we have lost connection. So yeah. Either you can connect with them or we go to the next session.
Next present. Sure, sir.
Call him back again.
Just once we'll call and then we'll get back to you.
Yeah,
sure.
Hello.
Yeah, Sushant, we can hear you.
Can the organizers please play my slides?
I think we can do that. Ekta, please do it.
Yes, sir.
Yeah.
Yes, sir. We have.
Yeah.
Yes, Sushant, over to you, please.
Sir, thank you. So that's what the importance of HRD is, that more patients we are able to identify. Next slide. Next slide. No, yes, this slide. So HRD testing is the newly diagnosed setting can establish the magnitude of the benefit confirmed by the PARP by using in BRCA mutated in highly this ovarian cancers, and identify the subgroups of BRCA wild patients who are more likely to benefit from the PARP therapy. Next slide. So whenever we are testing, this tumor BRCA mutation is one of the methods, and this genomic instability, which has these three methods: LOH, telomeric allele imbalance, and large scale state transition. Next slide. So when we have the report with us of HRD, how do we go about it in our clinical practice? First step is to know the report. Second, whether bevacizumab can be given to the patient, is it indicated or it is contraindicated? And third, the clinical characteristics, the stage, neoadjuvant chemotherapy versus primary surgery, residual tumor, platinum sensitivity beyond HRD status, and expected toxicity. So all these parameters needs to be considered when we have to decide in our day-to-day practice as when the olaparib needs to be given. So olaparib maintenance, upfront maintenance, when the patient is not relapsed and has come for the first time, how do we go about it? Next slide. Next slide, please. Yes. So we have these two pivotal trials. One is in cancer patients with any surgical outcome, and BRCA mutated patients were taken. They were given surgery followed by chemo, and olaparib maintenance were given in the solo one. And in Pola 1, similarly, newly diagnosed patients, any surgical outcome. In this, if we notice, we have BRCA mutated patients, non-BRCA mutated, HRD positive and HRD negative patients, and they were given along with chemotherapy, and in the maintenance, olaparib plus bevacizumab. So dual maintenance was given in this study. Next slide. So in solo 1, next slide. Next slide, please. Yes. So patients were randomized into 2:1 ratio with olaparib at 300 mg BD dose versus placebo, and 2 years treatment if no evidence of disease was there, and the primary endpoint being PFS. Next slide. So as we can see, the 2-year PFS is significant from the beginning itself. This pink color graph is of olaparib and the black color is of placebo. At the end of 5 years, the graphs are still separated, and there is significant PFS benefit of 56 months versus 13 months with hazard ratio of 0.33. Next slide. Again, the PFS2 time to second subsequent therapy is again, the blue line is significantly longer than the placebo. Next slide. Next slide, please. Now the side effects. We know that olaparib does causes fatigue, nausea, and hematological side effects. Anemia being the most common side effect. And we are now gaining confidence as to how to manage such patients with these side effects. Next slide. Now this trial of Palova 1, in which the HRD patients were also included and BRCA negative patients were also included. Again, the randomization was 2:1, olaparib for 2 years along with bevacizumab versus placebo with bevacizumab. Next slide. So unselected population was there based on the biomarker status. Then we had a pre-planned subgroup analysis by tumor BRCA mutant population, HRD and HRD mutant status, and active maintenance by bevacizumab. Next slide. So again, if we see that the PFS benefit in non-BRCA mutant population in PALO-1 trial is again showing that there's a PFS benefit when olaparib along with bevacizumab is given versus placebo with bevacizumab. And there was is about 7 months. So within 7 months, the patient was randomized to this trial. Next slide.
Sushant, 2 minutes, please.
Yes, sir. Yes, sir. So in subgroup analysis, all the patients benefited with olaparib with bevacizumab. Next slide. So treating non-BRCA mutant patients in PALO-1 trial showed that patients who are BRCA negative but had HRD positive had shown the benefit, and that's why even if the patient is BRCA negative, we should do HRD test to find out whether these patients will benefit or not. Next slide. Again, the histograms, the pink histograms are for olaparib with bevacizumab. They are longer than the placebo. Next slide. Next slide, please. So anyways, I think they're taking time. What the take-home message is that if patients are BRCA mutant, they definitely benefit from olaparib.